Hey, houseman, come here. Quickly do the PV of this patient and tell me what your findings are. And yes, also document it on paper. Imagine you are in first year of your residency and you have been asked by your senior to assess the pervaginal findings of a patient and you're just not sure if the findings that you're going to be documenting are correct. So welcome to the session wherein I'm going to be teaching you how to correctly assess and document your PV finding, and this is going to be by using a clay cervix and the two ischial spines. Now, very basic thing. Whenever you're assessing the cervix or just doing a PV examination of any patient, you need to know that you're assessing three things. The first is the mother, the second is your fetus, and the third are the things that connect the mother and the fetus. So when I'm assessing the mother or the maternal factors, in that I'm going to be assessing the cervical dilatation, then I'm going to be assessing the cervical effacement, or what now we also call as the cervical length. After that, I'm going to be assessing the cervical consistency, and then I'm going to be assessing the cervical position. When I come to the fetal aspect or assessing the fetus, I'm going to be assessing first of all the station of the fetus, and secondly, especially in second stage of labor, it is going to be assessing the fetal rotation. Now, this is not going to be possible in latent labor. It is only going to be possible in the later stages of active labor or in second stage of labor. When I'm assessing the parts that connect the mother and the fetus, the first thing is going to be the status of the membranes. Is it ruptured or unruptured? And secondly, if they are ruptured, then is there any leak that is present? And if it is present, then what is the color of the leak? Is it blood stained? Is it meconium stained? Is it clear? What is it? So this is how I'll be assessing the mother, fetus, and the parts connecting them. Now talking about the maternal side first. The first thing that I told you is going to be how to assess the dilatation of the cervix. Now remember that whenever you're sending these two fingers inside for assessing the vagina or the cervix, these are not your fingers but your eyes. You're sending your eyes inside, and these eyes have a great potential. The first thing that you need to do before sending this in is going to be to know what is the width of your fingers. Now for me, I know that the width of one finger is around 1 centimeter for me. I also need to know the length of my finger segment. So for me, till here, it is around 1.5 centimeters, till here it is 3 centimeters, and till here it is around 4.5 centimeters. You have to do this for your own hands as well, because most of the people in OBGY are women and their hands may not be as broad or as long, and hence you need to first assess the width and length of your fingers. So now, to assess the cervical dilatation, I'll be taking these two fingers and I'll be inserting them inside. Now I have inserted them inside and now I'm going to bring them out. Now I know that this is the distance between the two cervical lips. So this is 1 centimeter and this is another 1 centimeter. So this cervix is 2 centimeters dilated. If it would have been something more like this, then it would have been 1, that is 2, and in between it is around 0.5. So this would have been 2.5 centimeters. I also know that when I make a 90-degree of my fingers, which is like the maximum stretch that I can do, till this point to this point, it is around 10 centimeters, which is full dilatation. So you need to know what is the maximum stretch that your fingers can go up to. So now I know that the first finding of this cervical assessment is that the cervix is 2 centimeters dilated. Now comes the cervical effacement. So what is this concept of effacement? So this is your pre-labor or a gynecological cervix. This is not effaced at all. Now when you go in labor, because prostaglandins are released and a lot of hormones are released, remember that this cervix undergoes effacement. What is effacement? Effacement is basically it becomes paper thin. Why does it become so? Because the prostaglandins change the content and the concentration of the contents inside the cervix. So there is an increase in water content and is breakdown of cross-linking of the collagen fibers. Also, there is loosening of the smooth muscles inside, and that is why the dilatation and effacement starts happening. So, in comparison to this pre-labor status, I have to compare what is the status of the thinning of this cervix. So now I know that by looking at this thickness, it is around 50 to 60% effaced. But now the problem is, my senior might just feel that this is not 50 to 60% effaced, but it is 60 to 70% effaced. Maybe my junior will feel no, sir, that this is just 20 to 30% effaced. Now it's a subjective thing that develops with experience, and everyone's experience is different, and hence we cannot have something so subjective in an important process like labor. So in the modified Bishop score, we have substituted effacement with cervical length. So how do I assess the cervical length? Similar way as I did my cervical dilatation, I sent my two fingers in. I saw that this was the length of my cervix. So this was 1.5 centimeter and this was around, I would say, 0.5 centimeters. So the cervical length right now is 2 centimeters. So now I know that my cervix is 2 centimeters dilated and is also in length of 2 centimeters. Now I'll talk about the third and fourth aspect of the maternal side, and that happens to be the cervical position and the consistency. So consistency is very important and very simple as well. This was that pre-labor cervix and it was very firm to touch, whereas right now if you see that this is very soft. So you can either have it firm or soft or something in between, and accordingly you have to write. So for me, this is a soft cervix. Then comes the cervical position. Now whenever a female is yet to go in labor, her cervix is usually like this. It is facing posteriorly. As effacement and dilatation occurs, it gradually becomes like this, anterior, and that is going to help your labor. So whenever I'm inserting my finger and it is posterior in nature, I'm going to directly feel this cervix together. Both the lips are going to be felt together. So this is going to be posterior. When it is coming in between, or I can call it mid-post or central, then I'm going to feel this parallel to my fingers. Whereas when this is completely anterior, I'm completely going to be able to go into the posterior fornix and I'm going to feel the fornix. This is how I'll be assessing the cervical position. So it can either be posterior, mid-post or central, or it can be anterior. Of course, anterior is the best position for delivery to occur. So until now, I've assessed the mother, and what I know is the cervix is 2 centimeters, the cervical length is also 2 centimeters, the cervix is soft, and it is anterior right now. Great. Now I'll be assessing the fetal aspects. What are the fetal aspects that I need to know? The first important fetal aspect is I need to know whether the station of the, what is the status of the station of the patient. So it is very simple. Now a lot of people struggle with this. I have a very simple technique. Now remember to know that this tip of your finger, of the middle finger, and this tip is very important. So what I do is I go in with one finger like this, I touch the fetal head, and with the second finger, I try to touch, I'll just zoom in here, yeah, and with this second finger, I try to touch this ischial spine. Now, once I do that, I remove my finger and I see where is this tip. So this tip is positioned over here. So this is the distance of the fetus away from my ischial spine. So this happens to be around, I would say, maybe 2 centimeters. So basically, my fetus is around 2 centimeters above the ischial spine. So this means that my fetal station is -2. If the fetal station would have been in alignment with this ischial spine, then I would have called it dono same level pe hote aise. I would have said that the station is 0. If the fetal head would have been outside like this, agar aisa bahar aa gaya hota and the station would have been down, then I would have seen what is the distance and I would have said that let's say that this is that station. So it is +3 because the fetal head is ahead, is more towards me than towards the ischial spine. So a very simple way to assess the ischial spine is to keep your middle finger on the ischial spine and to keep this index finger, the tip of your index finger, on the fetal head. Remember, one thing very important is you have to look for the bony skull and not the skin, because the skin will often have caput succedaneum because of the collection of lymph in it, and hence you have to avoid assessing the fetal head by its skin. You have to go and touch the fetal skull and then check for it. Otherwise, you'll end up overestimating the station. Now, if your fetus is, let's say, in second stage of labor or in advanced active stage like 9-10 centimeters, then I can also assess the occiput of the station, or where is this fetal rotation. So if this is my fetus and it is coming down like this, and I can see like this inside over here, let's just assume ye aise hai. Now this is going to be occipito anterior. This is going to be left occipito anterior. This is going to be left occipito transverse. Similarly, on this side, this is going to be right occipito anterior, right occipito transverse. Now, this is something that is a little tricky and difficult for a lot of people, and it's okay if you're not able to assess it in your initial stages, but try to do that. And remember, do not do it when the patient is just 6 or 7 centimeters dilated, because while you're trying to insert your fingers to reach out for this occiput, it can be very, very painful for the patient, and hence you have to avoid making it painful for her. Hence, only do it mostly in your second stage of labor, when you can easily pass your fingers and you can feel this occiput behind the fetal skull. So now for the fetal aspect, I have the most important thing, that is the station, and for this patient it was -2. I'm not talking about the fetal rotation because this is just a 2 centimeters dilated cervix. Now, the next thing is going to be I have to assess what is the status of the things connecting them, that is your amniotic membranes and your fluid. Now over here I've not shown any membrane, but when you put your finger inside, if you can feel a plastic bag like bulge inside which contains water, then the membranes are intact. Of course, you can also put in a sim speculum and you can see if there is any leaking that is happening. If there is a leak, then document the color of it as well. So now I've done the entire examination of my cervix and the vagina, and my findings are: the cervix is 2 centimeters dilated, the effacement is 40 to 50%, or a better way to note it is the cervical length is 2 centimeters, the cervical consistency is soft, the cervical position is anterior, the fetal station is -2, and the amniotic membrane, let's say the amniotic membrane is present and does not yet ruptured. And finally is going to be whether the pelvis is adequate or not. Now I'm going to make a separate video on the adequacy of pelvis. I'll be teaching you that in a later class, but these are going to be my per vaginal findings. Now let me implement them to know what do I do next and what is going to be my next course of action. Now, as you can see on your screen, I have shown you the modified Bishop score. Now, if you look at the modified Bishop score, the cervical dilatation was 2, so it gets a score of 1. The next was cervical length. It was at 2 centimeters, so it gets a score of 2 again. Then I have cervical consistency, which was at soft, so a score of 2. Then I have cervical position, which is anterior, so again a score of 2. The station was -2, so the score of 1. And hence, my final score is going to be 1 plus 2 plus 2 plus 2, so that is going to be 7 and 1. So 8 is going to be my score. Now, whenever your Bishop score is 6 or more, it means that your cervix is ripe enough to go into induction of labor. Now, this is the biggest problem that a lot of people have, that they do not know what is the difference between cervical ripening and induction of labor. So to explain that, I'm going to show you another cervix now. So imagine this is your pre-labor cervix. You look at it. This is your pre-labor cervix. Now, if I'm to look at it, the cervical dilatation is 0. It has not yet dilated. This is the external os that you can see. Then the cervical length, if I'm to look at it with my finger, if I'm going to assess it, it is around 4 centimeters. The consistency is very firm. The cervical position is, let's say, posterior because it is still not in labor. And the station, of course, is very high because the cervix is not even started to dilate. So then the score is going to be, for the cervical dilatation of 0, a score of 0. For cervical length of 4 centimeter, it is going to be 1. For cervical consistency, it is firm, so again a 0. Cervical position, posterior, again a 0. And station is -3 or more above, so again a 0. So what I have is a score of 1. So for this, it was a score of 8. For this was a score of 1. Now, for any score of 5 or below, it needs cervical ripening. So what is cervical ripening? Cervical ripening is basically inducing the cervix or changing the cervix to have effacement and dilatation. And that is done using prostaglandins or Foley's catheter or mechanical methods like laminaria tent and everything. What we prefer to use is, of course, prostaglandins like dinoprostone. A lot of people even use misoprostol. Even ACOG 2026 does recommend using 25 microgram, but I am comfortable using dinoprostone gel. So when I'm using dinoprostone gel, what will happen is the chemical contents of this cervix will start becoming softer. The water content will increase in the stroma, and then from this cervix, I will eventually have a cervix like this. So this is called as ripening of the cervix, whereas when I talk about induction of labor, it includes the changes that are going to happen in the uterus, the contractions that are going to come, the descent of the fetal head that is going to happen. All of that is going to be included in induction of labor. So the cervical ripening has to occur first, and then it has to be followed by induction of labor. Often the same prostaglandin analogs that you use like dinoprostone act as ripening as well as inducing agents, which is why you don't tend to know the difference, but there is a big difference and you need to know it. This cervix only requires induction of labor. This cervix needed ripening followed by induction. So for this patient, what will I consider? I would either want to wait because she's still in latent labor and wait for her to go in active labor, or if it is proving to be too long, then I can just do an artificial rupture of membranes and wait for the dilatation to happen after that. And this is how you are going to be assessing the cervix and your vagina. Now, I have created a video which pertains to the mechanism of labor, and I've taught it using a real maternal pelvis and a fetal skull. If you want to have the link, comment pelvis in the comments below. You have to repost and like this video, and I will send you the link of the video which I have made to explain the mechanism of labor along with fetal and maternal pelvis, which will help you immensely in your exams and practical viva. So that's it from Dr. Adityan Conceptual.